This lecture is about multiple sclerosis. This is the last new neurodegenerative disease that we're going to talk about in this unit. Its name sounds a little similar to amyotrophic lateral sclerosis, and they have some similarities in that they can produce motor symptoms, and they both involve damage to the nervous system. But that's where the similarities end. ALS is primarily a disease of our motor systems, while multiple sclerosis can affect multiple systems, not just motor, but also sensory and cognitive and emotional, because the target for multiple sclerosis is the myelinating glia. So any pathway that includes oligodendrocytes, which would be all of them, could be affected. In the little animation that's playing here, we can see the emergence and then the disappearance of these sclerotic lesions. So this is how the disease gets its name. There are multiple sclerotic lesions within the white matter. So you can see some of them hang out the whole time, remain a relatively constant size, and then others grow and shrink over time. So here, these are just time-lapsed T2 weighted MRI images showing us the kind of dynamic nature of multiple sclerosis. So try to remember this image by the time we get to the end of the lecture. In the first part, we're just going to talk about the symptoms and prevalence of the disease, and in the second part, we're going to talk more about how it happens and what we can do about it. Multiple sclerosis is all about demyelination in the central nervous system. So we're killing off oligodendrocytes, and that's going to affect a variety of functions. Now, unlike most of the diseases that we talk about, old age isn't really a risk factor here when we're talking about multiple sclerosis. This tends to come on more around midlife. So you can see that in this plot. Rather than having the continual risk over time, we just get that kind of bell shape. So here we see something that's kind of like a normal curve here. MS is about 3 times more common in females, and it's far more common in areas that are far away from the equator, particularly those in northern climates, northern Europe, or the offshoots of them, which would be the US and Canada. And the idea behind this latitude-based risk is that in colder climates where you have more severe fluctuations in daylight, there's going to be a difference in vitamin D throughout the year. And so in periods where you have low sunlight, in winter months for example, where you have a greater chance of vitamin D deficiency, we tend to see a higher rate of multiple sclerosis in spring births as a result. Of course, that spring is going to be in different months depending on whether you're northern or southern hemisphere, but the relationship holds true where spring birth is a risk factor as long as you're far enough away from the equator, and autumn births decrease risk for MS. Now, it's not just that simple of what latitude are you at, because clearly you can see here countries at the same latitude line are going to have different risks. So there seems to be a racial component to the risk for MS. But it's also not that simple either, because as races move around, their risk adapts to wherever they live. So there's likely a mixing of environment, race, and culture, all of which are affecting some common underlying risk factor. And it may very well be vitamin D. So it could be the foods that people eat, the amount of sunlight that's available to them, and different propensities of the races to have vitamin D deficiency. So here we can see how races are going to adopt the risk for wherever they're living. So in these plots, we're looking at the prevalence of multiple sclerosis for males and females. Males are on the left, females on the right. You'll notice all the numbers for females are going to be higher. Again, sex is a risk factor here. The solid lines are showing us all white South Africans. And then we're going to look at different subgroups of white South Africans. The dotted line has the lowest risk, and these would be the white South Africans who have lived there the longest. And we can tell that because they speak the native language, so they speak Afrikaans. And those who still speak English but were born in South Africa, you can see kind of have an intermediate risk. And the fresh immigrants coming in from US and European countries have the highest risk of MS. And if we can go back to this graph here, you'll see that South Africa has a lower risk of MS than the US or Europe. So when immigrants move somewhere, they bring that risk with them for a certain number of generations. But as they live in that area long enough, they then adapt and their risk adjusts to where they're living. So a combination of all these factors are going to contribute to the risk of MS. Regardless of the risk factors that are causing it, the disease is going to look the same. We're looking for multiple sclerotic lesions. That's how it got its name. Multiple meaning more than 3. And sclerotic lesions, they get their name because they appear to be little hardened areas of the white matter. So we're going to see lesions in the white matter and multiple lesions in the white matter. As we saw in that opening movie, these are dynamic. They can change over time. Some can appear, disappear. They can change their size. And you can pick these up much better with contrast agents. The contrast agents are going to show us areas where we have increased blood-brain barrier permeability. Now, as the disease progresses and symptoms worsen, these white matter lesions produce gray matter lesions. So we see degeneration of the gray matter. Now, this image shown here is maybe a little too true to be good. What we're looking for here is the increase in yellow as you move from the top to bottom. So at the top, this is the early stage, and we're staging the disease based on symptom severity. So symptoms are more severe as you go from top to bottom. The color scale is showing us the degree of atrophy. So by looking at a very large number of patients with MS and noting the pattern of gray matter degeneration, they can create essentially an average sequence of gray matter degeneration. So the problems start in the white matter, but the damage to white matter then translates to a loss of neurons and gray matter damage as a result. So you can see going from top to bottom, the yellow spreads. In other words, the gray matter degeneration spreads throughout the central nervous system. And that's going to cause a variety of sensory and motor symptoms. Most commonly, we're going to see fatigue, spasticity, and incontinence. And that has to do with some of the areas that are being affected first. Undoubtedly, the cingulate cortex is one of the initial targets in multiple sclerosis, and that's going to have important functions with controlling our bladder. Depending on where we have degeneration, we can have sensory issues, motor issues, a combination of the two, but certainly numbness, pain, weakness, these are not uncommon. Here we'll hear from a gentleman who has multiple sclerosis.
Started to just feel a bit run down, and I'd been feeling a little run down for a while, and that just increased after I left the job, and it just got worse and worse and worse. But I figured at that time it's not going to last. It'll be a few weeks. I'll take some time off between jobs, and then when I start to feel better, I'll start applying for other jobs, and I'll get myself back to work. This lasted for a few months, and after about four or 5 months, I started to think there might be something more seriously wrong with me. That's when the tingling started, the tingling sensation in the feet. That led to pain in the feet, pain up the leg. Then I started getting cramping. I started to have balance problems. And then I started to get numbness with the pain. I started to have pain in the lower part of my leg, and then the numbness started in the groin and worked its way down. So it was like they met in the middle.
So pain is not an uncommon symptom. And the reason for that likely has to do with the loss of myelin and the transmission of action potentials from myelinated to non-myelinated axons. This is something that we call apoptic transmission. You can see this in the peripheral nervous system, but it can also occur in the central nervous system as well. So, in multiple sclerosis, what happens is the loss of myelin. So whenever we have a demyelinated region, when we fire an action potential, and that travels down the axon, we're going to have a section of the axon here that used to be myelinated and no longer is. So in order to propagate that action potential, we have to reinsert new ion channels. Now, we have depolarization, repolarization, and that repolarization is caused by potassium efflux. Normally there's not a whole lot of potassium efflux that occurs in a myelinated axon because we're only moving ions at the nodes. The nodes here are usually just about 2 microns in length, and then our inner nodes are going to be somewhere between 100 to 1,000 times that length. So we're going to have a substantial portion of the axon now that's going to be leaking out potassium. And those non-myelinated fibers that are nearby are going to be exposed to an increase in extracellular potassium. And we've seen this before. Whenever this occurs, it causes this cell to depolarize. And if it causes it to fire an action potential, then we feel pain, even though there's not any painful stimuli there. Just the loss of myelin leading to the excitation of nearby non-myelinated axons. This doesn't occur normally whenever we have myelination because we don't leak out potassium. There's just very finite regions where we leak out potassium. But now we have potassium exiting the cell in unbuffered regions because this used to be myelinated. There was no need to clean up potassium here before. When that myelin is gone, this can lead to the involuntary activation or the inappropriate activation of pain fibers. And these pain fibers are very excitable because they're very, very small. So it's easy to build up a potential within them. Now the little animation that just happened down there where potassium leaks out of this cell and goes into this one, that's an okay way to think about it. It's not totally accurate. We'll build on this a little bit more next year. But it's not surprising that pain occurs in demyelinating diseases. The demyelination itself is painless, but the transfer of action potentials from non-painful neurons to pain-sensing neurons is painful. And this is caused by demyelination, which is likely from autoimmune targeting of oligodendrocytes. So our immune system is going to break down oligodendrocytes. So improper targeting of myelin proteins by our immune system coming in, breaking down the myelin, this is what's going to cause MS. So immune cells that are incorrectly targeting the myelin sheath are going to expose areas of the axon. So multiple sclerosis is going to involve a couple of things. First, we have inappropriate targeting of myelin. Second, we have invasion of these white blood cells into the central nervous system. So we can see this whenever we analyze the cerebrospinal fluid of MS patients. You can see an elevation in white blood cells, not in all cases, but that is one sign of MS, along with, of course, the clinical symptoms and the imaging. You can also see an increase in antibodies that are entering the central nervous system. So if you analyze their cerebrospinal fluid, looking for an elevation in immunoglobulins and looking for a couple different types of immunoglobulins, it's called the oligoclonal bands. The presence of those two things is a pretty decent diagnostic tool. You can see the sensitivity and specificity given here. So somewhat sensitive, so sensitivity about 71%, a little more specific, 80% there. So you can see in people who don't have MS, they tend to be rated as negative by CSF analysis, and those with MS tend to be rated positive. This, along with your clinical symptoms and imaging, are going to do a decent job of diagnosing the disease. Imaging is the best tool for diagnosis, though, undoubtedly. Certainly seeing those dynamic lesions is going to give the diagnosis of MS. So when we have demyelination, a couple of things are going to happen. Aside from producing that pain, we're going to have symptoms. Now, depending on whether we're affecting sensory or motor symptoms, that's going to determine whether we have sensory or motor deficits. If we have loss of myelin in emotional circuits, we can see those mood symptoms that come on in MS, so feelings of depression, or if we have demyelination in memory circuits, we can have memory impairments as well. So initially what happens following acute demyelination is that we just have a section of bare axon. This used to contain myelin, so in that, what used to be internode, we have no ion channels. So immediately following demyelination, the action potential can no longer propagate through demyelinated regions. This is undoubtedly going to create sensory abnormalities and motor weakness. If we can't conduct an action potential, we can't relay the message. This is going to resolve as we insert additional ion channels. And now, the action potential can propagate again, but it's just slower. So we have a slight slowing of action potential propagation. This can lead to the kind of slowed cognitive function. It's slower and it's also less energy efficient. So have a look at this micrograph here. So we're looking at, in green, just neurofilaments. That's just showing us where neurons and their dendrites and axons are. In this case, we're looking at axons because we're also looking at myelin. So myelin is shown in red. And you'll notice there are areas of the axon where we have exposed green. Those are demyelinated regions. If we're passing an action potential along that region, that means we're opening up a whole bunch of ion channels. And we're letting sodium move in. That's going to give us our depolarization. We're letting potassium flow out. It's giving us our repolarization. Of course, we have to then pay for our sodium-potassium pump. This is going to increase metabolic stress and eventually lead to the loss of neurons, and that is when we see our gray matter degeneration. So it's the same old story. We increase the metabolic burden on these neurons, and they can only last for so long. So as the disease progresses, and we move down in that graph from a few slides back, and we start to see degeneration of the gray matter, that's likely going to be caused by oxidative stress from from having to fuel that sodium-potassium pump. Because without myelin there, those action potentials become far less energy efficient. We're always sensing, we're always moving, and these fibers are going to be myelinated. And there's a good reason. They're moving, they're conducting messages constantly. So in order to keep the ATP cost low, we myelinate them. When that's lost, we have oxidative stress and neurodegeneration. There's also some evidence that improper clearance of glutamate or excess production of glutamate might underlie the neurodegeneration in MS. This is also not a new story. We've heard this in other diseases as well. So anytime you have reactive gliosis, so if you have, let's say, loss of neurons, and you need to clean up that damage, we have reactive gliosis, just like we discussed in last lecture and previous lectures. Our excitatory amino acid transporters could be downregulated so that the reuptake of glutamate into astrocytes doesn't occur. So when we have damage leading to reactive gliosis, this downregulates glutamate transporters. We don't pick up the glutamate, that leads to excitotoxicity. And we do see an elevation in glutamate concentrations in the plasma of patients with multiple sclerosis, at least in most cases of it. This could be caused by impaired uptake. That's always a possibility. Or maybe these astrocytes aren't buffering the potassium as well. Astrocytes are going to be one of the cells that will clean up that potassium that's getting ejected on every action potential. If we don't clean up potassium, that's going to excite neurons. If we don't clean up glutamate, that's going to excite neurons. And it's also a possibility that the white blood cells that invade our central nervous system are contributing to this as well by spitting out glutamate. So that foreign invasion of immune cells not only could target myelin and break that down, but they can also then release glutamate and drive excitotoxicity. Excitotoxicity not only in neurons, but also in oligodendrocytes. So in these data, we're looking at the viability of oligodendrocytes. So on the y-axis, they're essentially showing you healthy oligodendrocytes. And on the x, we're looking at the concentration of AMPA that they've applied. As we apply higher concentrations of AMPA, cell viability goes down. On the bottom there, they're showing you the same thing. So they have the wash, which is just a control. Apply some AMPA. AMPA is going to stimulate glutamate receptors. That's toxic. Then they have that final bar where they add NBQX. This is an AMPA receptor antagonist. If we block AMPA receptors, then we don't experience that toxicity. So just like in other disorders, glutamate toxicity could be contributing to the loss of oligodendrocytes and neurons in multiple sclerosis. And because we're not targeting neurons, rather than being just a strictly progressive disease like ALS, MS can have periods of remission. And the most common type of multiple sclerosis is going to be that relapsing, remitting multiple sclerosis, where we see symptoms come on and then we see symptoms go away. When that occurs, so this will be our symptoms, and at the top, that's worse. Relapsing, remitting. These can be over variable periods of time, but the symptoms need to last at least 24 hours. And then they will remit for some period of time. Could be a month, could be longer. The onset of symptoms is going to be caused by demyelination. And then the remission there is going to be caused by remyelination. And this can go on for some period of time. And for about 20% of patients, they will continue to have relapsing and remitting. They're going to remit and come back to normal levels of function. Doesn't always happen though. At some point, about 2% each year are going to progress. So they never come back down to baseline, where they're normal, whatever that means for them. Failure to come back to baseline is what we see in progressive forms of multiple sclerosis. If you have periods of relapsing and full remission, then you have what we call secondary progressive MS, because the progression is after the relapsing and remitting MS. Not every case has those relapsing and remitting periods. Some cases just start off progressing, and that would be primary progressive. We call it secondary progressive because it happens after the relapsing and remitting MS. So you'll still have your good days, your bad days, but the good days will get worse over time. Now this here, this shift in baseline, that is more likely to be caused by neuron loss. Because we can make new glia, but we can't make new neurons, for those sensory and motor neurons anyway. The birth of new neurons occurs in very limited areas of the central nervous system. So progression is going to be caused by neuron loss, just like what we'll see in ALS. ALS is caused by the death of motor neurons. It progresses, it only gets worse. You're not going to see remission, because once those neurons are gone, that's it. They're all special, just like you. Now, as far as treatments go, we have a couple of options. There's a couple of first-line treatments that are going to have less severe side effects than second-line treatments. We can actually modify the course of the disease with these treatments. They all have the same underlying mechanism in common, and that is to prevent the immune-driven loss of oligodendrocytes. And there's a few ways of doing that. You can suppress immune function. And that's what our interferons are going to do. They're going to have anti-inflammatory effects. Acutely, you can use corticosteroids. They're not going to modify the course of the disease, but they'll help reduce inflammation. The disease-modifying treatments, though, the first lines would be the interferons, and then there's glutamyl acetate. So interferons are simply going to stimulate anti-inflammatory signaling. This glutamyl acetate, what you should think of this as, is just a whole bunch of little proteins in there, a solution of proteins that look a whole lot like myelin. So it's just a random assortment of peptides that mimic myelin proteins. And by putting our glutamyl acetate into patients with MS, what we do is give their autoimmune targeting something else to look at. So we're going to load up immune cells with these little peptides. So rather than targeting our oligodendrocytes, they instead chew up some junk we don't care about. That's of course going to stave off the immune targeting of oligodendrocytes. This is essentially going to compete with myelin binding. We also see an increase in neurotrophic release with glutaminyl acetate, and that would help too. So neurotrophins are just proteins that are going to prevent cell death in neurons. That's kind of their job. So by preventing inflammation, by preventing the white blood cells from entering the central nervous system, and there's a few different ways that we can do that. The interferons are going to decrease the permeability of our blood-brain barrier so that stuff in our blood can't enter the brain. Other treatments are going to either bind to the peptides that are targeted by white blood cells. So I could have this wrong, but I think it's alpha-4 integrins or something like that. These are proteins that are going to get latched onto by white blood cells and be used to transport them into the central nervous system. One of the second-line therapies is an antibody that targets this. So it essentially masks the binding site for white blood cells to enter the brain. Other therapies are going to hold white blood cells in lymph nodes and prevent them from circulating around. These have worse side effects than our first-line treatment options there. And we can see in this plot how effective interferons are at preventing that progression. So going from relapsing remitting to secondary progressive, this is the event we want to stop. Because while this is pretty bad, this is far worse, that inability to ever go back to baseline. And you can see here that in the group treated with interferons compared to placebo, we had about a 1/3 reduction in progression from relapsing remitting to secondary progressive MS. And that's pretty good. Alright, I got a few questions for you here to go over before class. If you have any for me, add them to the website. I'll see you later.